Hello, everyone. I am Dr. Muhammad Tawab, co-chair of ISPRM Communication Committee, and today we have with us a very esteemed guest, Professor Fary Khan. She is the Director of Rehabilitation Services in Royal Melbourne Hospital, Australia, and she was the ex-chair of ISPRM Disaster Committee, and today she has given us some time from her very valuable time to discuss and actually teach us about what disaster rehabilitation is. She has over 180 academic papers, and she has had multiple academic positions in various international organizations. And without any further ado, I would like to welcome Professor Fary Khan. How are you doing today?
Thank you very much, Tawab, and hello, everybody. It's very late in Melbourne, so hopefully I can answer the questions and give you some information that's of interest. I'm very happy to be here and to share my experiences because I know there's so many people within the ISPRA membership who do such excellent work in austere environments and in disaster settings. So it's a real privilege to be asked to speak here tonight. Thank you.
So, Professor Khan, in your experience, what kind of disasters have you worked in and provided rehabilitation services?
So, very interesting question. So, disasters vary. So, I've been a rehab physician for over 24 years. And in that time, we've had opportunities to look at a number of austere conditions. And that means, post floods, places like Pakistan, for example, post floods, or Bangladesh, or places like Sri Lanka, or earthquake situations like Nepal, and also more austere food hunger type places where people are displaced, refugee crises where people have had to move because of a man-made disaster, for instance. So, I have been fairly fortunate in being able to contribute small ways in a number of those situations, particularly in our region. As we know, in the Asia Oceania region, we have too many tectonic plates, for example, and in the Southeast Asian region, in particular, places like Pakistan, where I was born in, and where you come from, Tawab, Afghanistan, which is up in the north, Iran, which is to the east, and also places like Nepal, which is a little bit up to the north. It's very prone to earthquakes and landslides. And now, with more and more climate change, for example, with floods and with change in rainfalls and landslides and a lot of other sort of disasters that are often not spoken about. Are becoming more frequent. So I've had the good fortune of learning in those situations and being able to work with a number of local rehab physicians and local government people, local university personnel who've invited not just myself but also our team in Melbourne at the Royal Melbourne Hospital Rehabilitation Medicine Department, where we have the flying faculty that some of you know about. So in the last 20 years, we have been deployed to over 12 or 15 countries, and some we go repeatedly, every year. Of course, COVID was a big disruptor for us because of travel restrictions, and I don't know if you know, but Melbourne had been in complete lockdown for nearly 2.5 years, so the most locked down city in COVID in the world. So, we weren't able to do our normal work, but we were able to then transpose some of the work that we did in person in terms of master classes, education, capacity building for local populations in the Asia Pacific region in particular, where we contributed to how to upskill the rehab workforce, for instance, and help reestablish the clinical services in small ways by helping triage patients in crises, like in earthquakes in Nepal, for instance. There we were deployed under the WHO as an EMT. They were called emergency medical teams. They're foreign medical teams, then now they're called EMTs, emergency medical teams. So we were deployed for just under 2 weeks at that time. In 2014, I think it was. It was pretty devastating. We were one of the first teams to arrive in Nepal, in Kathmandu. We were deployed by the Ministry of Health in Kathmandu under the auspices of the World Health Organization to a spinal center in Kathmandu, where we worked with the local Nepalese doctors. Then we had Raju Dhakal, who was the only rehab physician then in Nepal. Of course, now there are a number of other young physicians as well. But we worked with Raju and his team, and it was pretty awesome. The spinal center was only catered for about 25 or 30 spinal cord patients. And when we arrived, we had over 80, 85 people. So they were just everywhere because the situation was so bad. Lots of people had died, and a quarter of Nepal had been affected. Kathmandu had been affected in terms of, collapsed housing, collapsed infrastructure, roads, and it was just difficult to get food. Electricity was hard. There was hardly any internet. Phone lines didn't work. Water, petrol, those sorts of things, accommodation were very tricky. So we were very lucky because one of my colleagues, Dr. Amatya, who you know, Bhaskar Amatya, he's Nepalese, and so we were very fortunate because he assisted the Royal Melbourne team to find accommodation and food and transport in a very disaster-stricken area. So we were very fortunate in that. But more importantly, we were able to look at people who had severe traumatic spinal cord injury, and we had about over 100 patients by the time we left. And the range of injuries was from lower lumbar, mid thoracic spinal cord, complete injuries to incomplete paraplegia. So there was a huge range. And the common injuries were sustained by women and children because the earthquake happened on a Saturday around lunchtime when most families were having lunch. And so it was quite difficult to see mainly women and children affected in that context because they were home at the time. The other interesting thing was that we had a few tasks that were requested of our Nepalese hosts, and these included assistance with triaging the patients, and having more customized rehabilitation plans, supporting the allied health and the medical teams as able, given we had only one rehab physician in the entire hospital, which is Raju at the time. He did a wonderful job. And we were asked to assist with, looking at bladder and bowel training, for example, and education of the patient and families were pretty devastated because a lot of them had lost their home, lost everything, and lost their jobs as well. So it was quite, humbling, I think, in my opinion, to be able to look at the difficulties, the pain, and the issues facing those very brave people and how they were able to be so resilient and carry on. And I think, in my mind, one of the most interesting instances in that stay in Kathmandu, for me, was during day 3 or 4 when we were finishing our ward rounds in the hospital. We had the second earthquake. The second earthquake was pretty devastating. It was between 6.5 and 7 Richter scale, so very severe. And we had just finished the ward round looking after all of these 100 odd patients. And it was terrifying because the walls started to shake, and the patients were reminded of the recent trauma they'd had. And even with the paraplegia, they were crawling on the floors and trying to get out. And so our team was able to, manually carry out 20 or 30 quadriplegic and paraplegic patients outside. And so while the Ministry of Health looked at the stability of the hospital, the building itself, to ensure it was safe for patients and doctors and other medical and non-medical staff, it was pretty scary as well at times. But we were able to look after those patients outside in the grounds while this safety work was being carried out. And it was quite difficult because the people there did a wonderful job. The tents were put up immediately, but it was monsoons, it was raining as well, and many people were being nursed on the floor, on the garden, on the ground, and it was difficult because of pressure injuries and just the fact that we had to turn them a lot, and we didn't have the staffing and all that. So it was very interesting. Another interesting element was we didn't have any splints, we didn't have any equipment that way, and we had a lot of people who had immediate spinal fixation surgery and required some form of bracing. And we had an orthotist with us from our hospital, from the Royal Melbourne, and we fashioned splints with whatever we could find, like bicycle spokes and whatever else, to just make ends meet at that time. And we had some fantastic physiotherapists with us. Professor Mary Gillier was one of them, and some of you are familiar with her work. And she was just tremendous in how she helped with the mobilization and getting the local physiotherapists, do the state-of-the-art type of work with those very difficult, limited resource environments. And I think, lastly, one thing that we did miss a bit was that we didn't really have a psychologist on board. And as we were in that situation, there was a lot of post traumatic stress disorder type picture, even though it's very early, like it was week, 2 weeks down the track, and a more recent earthquake as well, which terrified everybody, including us. So I think the psychology part was what we had underestimated, in my opinion, from our team perspective. And as team leader, for me, it was hard to see people's distress and people's fear and how they responded in that incredibly stressful situation. So I was very proud of my team. So we didn't leave our posts, we were there for the whole time. And we supported the Bangladesh team. Professor Taslimuddin was there a day before us, so he did a very good job as well. And when we left, we handed over to the Malaysian rehabilitation team to carry on the work under the WHO auspices. So this is just one of the many stories that we've had, a lived experience.
So, Professor Khan, in your experience, what were the things that you think that worked really well in these situations?
I think a cool head. I think, firstly, we're not all trained in being deployed to disaster settings. And no matter how tough you are and how experienced you think you are, it's always a little bit of a shock to the system. No matter what anyone says, that's my personal opinion. And for me, I trained originally as an emergency registrar and a trauma registrar, surgical registrar. So, I was pretty confident that, I could deal with any medical situation that came my way, other than surgery, of course, at that time. And so the biggest challenges from our perspective in that context were underestimating the number of patients. It was a big barrier because we weren't prepared. There were no medicines, painkillers, for example. To remove stitches, for instance, wounds, we didn't have any incubators or sterilizers. So we had only one or two wound cutters, and it's really not good practice to kind of use non-sterile things. So we had to make do with what we had and sterilize things in very primitive ways, that we had to do. And so resilience of the team, the fact that, I'm a physio and I can't do X because that's something that the OT or nurse does, or I'm a doctor and I can't do what a physio does, that was not there in our team. So we really did this task allocation. Whoever could do whatever, did whatever they could at the time. We were also very fortunate because there were a number of Chinese volunteers who were very kind people who came. And so we used them as hospital assistants, if you know what I mean, who would just porter the patients back and forth, or turn them or spray them with mozzie repellent so they wouldn't have flies sit on their wounds and stuff like that. So resilience, I suppose, is one important element in a team. Keeping your nerve and keeping cool. When the second earthquake happened, the first response of everyone was to just run away somewhere. Where do you run away in such a situation? So you really have to just ground yourself, and as team leader in particular, you're responsible not only for yourself, but the patients and your team. Your team is fully dependent on you for guidance and for I suppose, to stay resolute in the mission that you've been allocated. And you can't just run away and leave everything and be gone. That's not going to happen. And in this case, that was never a thought. In fact, we did have to talk about an exit strategy for the team when the second earthquake happened, because there's only one main road through the Kathmandu city, and it was like a ribbon at the end of the earthquake. So it wasn't like, we had many places to go to. But I was very proud of my team, because when I asked them what they wanted to do, whether they wanted to leave, they all wanted to stay. And at that time, there was no way to go anyway, but they all wanted to stay. So I think team resilience, good leadership, and good directions, and safety, and caring for the people you're meant to care for, but also caring for your team, was to me some of the really important elements. We had a lot of support from my colleague Dr. Amatya's family, so we had somewhere to stay. For example, we had water and food, which was quite scarce at the time. So having those resources and planning ahead for your mission is really important, because you can't just be a burden on the people who've invited you, because they're struggling as is. So that's why it's a further challenge when you are deployed to low resource and middle and low income countries, that you have to be fully self-sufficient, and that's one of the hardest things. We were also lucky because we had a lot of people who know the culture of Nepal, for example. I can understand a bit of Hindi, Nepalese, and so it did help. And we had other team members who were also culturally very aware. And there were other EMT teams as well, and I thought we were better prepared for that cultural expectation because of the multicultural nature of our team. Rather than, we could speak the local language and we could communicate a little bit better with the families of those patients who were terrified in those instances. So I think these were the positive things that I would recommend that EMT teams consider. But there is also a course that is run by the National Trauma Response Center in the Northern Territory in Darwin in Australia. And I was very fortunate that after my deployment to Nepal, I did go and complete the course and did the training for disaster management there, where they teach you how to drive a military convoy, for example, how to get out of difficult situations, for instance, how to handle aggressive crowds, how to detonate and avoid grenades, for example, and how to be deployed in difficult circumstances and survival tricks. And that to me was very much an eye-opening experience and helped, I suppose, consolidate some of those skills. So when people have asked me from our various ISPRM members about, how they could get that training, well, there are options that are available. Of course, Australia has a center, but also Dr. Reinhardt in China, in West China City, in Sichuan. He has a emergency response a simulation center, and I have visited that, and it's excellent. And I have always requested the DRC Disaster Rehab Committee members who are interested to perhaps contact him and have a formalized training program that could help upskill. One of the other interesting things that I hope that we can do in the future under the auspices of the ISPRM is to have a registry or a list of people, young rehab physicians, hopefully, who are, and not so young also, who are willing to be trained and to be deployed should there be a disaster in their region, and should the WHO ask for assistance from those rehab physicians in those regions. So, for example, a European team, there could be Asia Pacific team, and there could be an African, North American team, etc. I think that would enable ISPRM to respond more effectively in a more timely manner, so that when such a request comes, people are more or less trained and they have had the capacity building, the training, some training at least, if not a lot of training, so that they're better equipped to assist in those circumstances.
Interesting to listen your experience and listen to what you went through, to providing care in a really new, situation. So if you would just like sum up, what are the, for example, the lessons learned from your like vast experience of over
Yeah.
20 years for in terms of disaster rehabilitation?
Okay, so I think the lesson is that disasters are up and up. The numbers of disasters are rising. The population is exploding all over the globe. So sooner or later, most regions are going to have some form of disaster. Natural disasters are more common in the Asia Oceania region, as for reasons I've mentioned. We have most tectonic plates, and also we have more landslides and climate-related events. And at the same token, you have famines and starvation and all the lack of rainfall in other parts of the world. But from our perspective, I think earthquakes and weather-related changes are on the rise. So we need to be prepared. Number one, we do have climate related. We have a special interest group, I think, run by Mark Haley Alexander on climate change, and I think that's a very good thing to have, because people can be more aware of what medical people can do to assist with climate change and the impact on health. If we are to be effective as an ISPRM, DRC, a disaster rehab a committee and deployment, working with the WHO, the EMT program, then it's probably essential for us to have a list of interested people as a first step. And if you are interested, then you should contact the DRC to Dr. Farooq Rathore and his colleagues and his team, and maybe have some form of training. Because no matter how clever or how skilled you think you are, you will be surprised. There's always very many challenges and you face in those austere environments. And often people are very ill prepared. And that is a disaster in itself, because you're going to help people and you become somebody who needs help. So that's no good to anyone. I think training and upskilling in those contexts with practical experience. It's not okay just to read a book and turn up. No matter how good your intentions are, that's not very helpful to the people. So you need to have some generic medical, surgical, rehabilitation type experience where you can take in the environments. So you're not expected to kind of stay in a hotel and have nice food and have all the luxury and comfort. It's pretty rough, and you need to be prepared to be able to do that. In the Darwin course that I did, you had to carry your own tents and put up your own tent and set up your own facility and look at all the infrastructure and all the logistics and all. And those sorts of things are not usually the strong feet of rehab physicians, because we're not taught some. So we need to teach ourselves all those skills in order to be effective. In my opinion, the more prepared you are, the better it is. From our perspective, it's probably better for the rehab physicians to be deployed perhaps after the acute search and rescue is over, because we're probably more useful in that context. And I think that the WHO AMT guidelines sort of mandate almost that rehab medicine assistance, if required and if requested, should be for about a period of 12 weeks. And that's a challenge for many of us because we have jobs and families, and it's always hard to get those sort of 12-week marks. So, there's some flexibility where people can replace others and ensure that there's some form of rehab physician presence when requested in such circumstances for up to 12 weeks. I also think it would be great rehab physicians read up the EMT guidelines published by the WHO. And even the Journal of ISPRM, there are a number of publications where, basically this evidence base for what might be required of a rehab physician in a disaster or austere environment. So being better prepared is better. It's no good just turning up to help, because that doesn't help anyone. And last and not the least, I think, of course, you're responsible for your patients, and therefore, wherever you're deployed, you need to ensure that you fulfill the mandate given to you, not what you think you should be doing, but what is asked of you. You have to fulfill that, irrespective of what you might want to do yourself. Okay, it's usually led by the local health departments, and that's incredibly important because you're there to support them and also to educate and expand their work base so they can be better prepared for a similar disaster if it happens in the future, and they're not dependent on external people to come in and assist them where possible. And last but not the least is the psychological wellness, I suppose. When you are deployed, you see a lot of pain and a lot of difficulty faced by people, and it's very confronting. For me, as a team leader, one of the hardest things was to debrief my team every night. And that was the hardest thing for me. And because the situation I saw was so tragic, there was so much loss of life and so much disability in young people, and so much functional loss in poorer countries like Nepal, where if you lose if your main wage earner is injured, the whole family suffers, and there's not a lot of social support and financial services to fall back on. So for me, debriefing my colleagues was very difficult, and also it's not always easy to keep absorbing people's misery and pain. So you have to really look after yourself as well. So when we came back, for example, from Nepal, I organized a psychology session for our team, a number of those, and I attended all of them myself. I also requested all my team members to attend, and they do help because they just make you understand that you're only human, and each person has their own I suppose, capacity to absorb the terror, the sadness, the hurt of other people. And I know many people who've been once, but they will not go back again because they found that the most traumatic element to cope with. So the psychological support for your team and also for yourself and self-preservation, so you can actually go and help for a second or another time, is probably very, very important consideration.
Thank you so much, Professor Khan, for these valuable insights, and hope to see you soon in the upcoming ISDM conference in Sydney, which is just
Yes.
around the corner.
Thank you very much, Tawab. It's always a pleasure talking with you, and you and your communication committee are doing a fantastic job. So thank you very much. And I look forward to seeing yourself and all our other colleagues in Sydney. Please remember, it's in the first week of June. Registration is open, abstracts are open, and we are so looking forward to seeing you all of you there. Thank you.